I'll make it quick. Starting with the first case, labs show hour rods, myeloperoxidase positive inclusions, increased circulating myeloblasts, 15-17 translocation. Your diagnosis is APML, acute promyelocytic leukemia. You treat with all-trans retinoic acid. Some new information for you. Patient will present with a pancytopenia, low hemoglobin, platelets, and leukocyte count with associated symptoms of fatigue, easy bleeding, bruising, and infection. Your labs will show elevated PT, PTT, and low fibrinogen indicative of DIC. Your DIC is caused by hour rods entering the bloodstream. Next case. A child with Down syndrome has B symptoms, facial swelling, hepatosplenomegaly, cervical lymphadenopathy. Labs show pancytopenia, increased lymphoblasts on blood smear. Your diagnosis? ALL. Your treatment is chemo. The Philadelphia chromosome 922 translocation is associated with poor prognosis in these kids. Next case. A 72-year-old male has B symptoms, recurrent infections, and lymphadenopathy. Your labs show increased monoclonal lymphocytes. You get a CBC with a smear, which is your best initial test for this condition, and it shows smudge cells. Your diagnosis is CLL, chronic lymphocytic leukemia. Your most accurate test for this condition is a bone marrow biopsy and flow cytometry, which will show CD5 and CD23 markers on those smudge cells. The recurrent infections are due to the lack of functional antibodies from the proliferative B cells. Next case. 65-year-old male presents with weight loss, fever, fatigue. Your CBC shows a high white blood cell count. A FISH analysis shows a 922 translocation. Your diagnosis is CML, chronic myelogenous leukemia. Your treatment is with a tyrosine kinase inhibitor, like imatinib. Remember that 922 translocation causes the BCR-ABL fusion protein. CML is often confused with leukemoid reactions. Leukemoid reactions occur when a patient with a regular infection presents with fever and a high white blood cell count. It's similar to CML, but it is a normal physiologic response to infection. To tell the difference between CML and leukemoid reaction, we look at one thing, the LAP, leukocyte alkaline phosphatase level. LAP marks more mature neutrophils, which are present in infection and are present in normal left shifts. That means that the LAP level will be high in leukemoid reactions, but low in CML, because in malignancy, you only have immature neutrophils. You can think of it as the more mature neutrophils running laps, or LAP laps, around the body to fight off infection. Next case, pancytopenia, splenomegaly, and cells that stain TRAP positive and have fuzzy cytoplasmic projections. Your diagnosis? HCL, hairy cell leukemia, and you treat this with cladribine. So, hairy cell leukemia presents with pancytopenia. Another common cause of pancytopenia I want to compare this to is aplastic anemia. In aplastic anemia, however, you do not get hepatosplenomegaly. And why is that? In other cases of pancytopenia where you have bone marrow aplasia, where the hematopoietic stem cells are being destroyed, you do not have extramedullary hematopoiesis. And this should make some sense. If the stem cells themselves are being destroyed, then no matter where they go, if it's the spleen or the liver, to try to complete extramedullary hematopoiesis, they will still be destroyed. However, in cases where the bone marrow is being infiltrated, like malignancy, like hairy cell leukemia, or myelofibrosis, where the space, the bone itself is being filled up with collagen, the stem cells can escape. They pack up shop. They run away to the liver and spleen to set up shop there. But in bone marrow aplasia, like aplastic anemia, you do not have hepatosplenomegaly. That's a key difference. Pancytopenia occurs when all three cell lines are low. In neutropenia, only one cell line is low, the neutrophils. And a common cause of neutropenia that you should be aware of is drug-induced neutropenia. Your hyperthyroid drugs like methimazole and PTU can cause drug-induced neutropenia. TMP-SMX, clozapine, and sulfasalazine are also high-yield ones you should know. They present with ulcers, usually within about 3 months of drug exposure, and the treatment is to discontinue that medication. Final high-yield facts on Hodgkin's lymphoma. Remember, Hodgkin's lymphoma has a bimodal age distribution and presents usually with painless peripheral lymphadenopathy, fever, pruritus, and your famous Reed-Sternberg alloy cells that are CD15 and 30 positive. Something new may be that they present often with a mediastinal mass. You evaluate them with a PET scan, you treat them with chemo, and post-treatment is often high risk for solid organ secondary malignancy as well as cardiovascular disease. Thank you for listening.